Marvin Goldfried is a distinguished professor of psychology at Stony Brook University, where he helped to develop the graduate program in clinical psychology. He's the co-founder of the Society for the Exploration of Psychotherapy Integration. Alan Francis is a professor of psychiatry and chair emeritus at Duke, and was chair of the DSM-IV task force. Marvin describes the evolution of his psychotherapy orientation as psychodynamic, behavioral, CBT, and eventually integrative. He practices, teaches, and supervises what works clinically using direct and indirect evidence base. Alan describes his approach to psychotherapy as whatever works, or no one-size-fits-all. He was trained and taught at the Columbia University Psychoanalytic Center, but remains equally interested in brief, supportive, cognitive, behavioral, interpersonal, and family therapies. Please enjoy this week's episode.
Welcome to Talking Therapy. I am Marv Goldfried, and my colleague here is
Alan Francis.
And today, Alan, you wanted to know a little bit more about how I got involved in the whole area of integration.
Yeah, I think to put this in context, for the last, say, 120 years of psychotherapy, the field has been mostly schismatic with different schools. So we now have 50 different brand names of psychotherapy and a kind of competition amongst them. And Marvin was really the pioneer going back to the 70s, seeing the future would really importantly bring the different kinds of therapy together. And now so many therapists are stuck in one model. I think it'll be interesting for us to discover more about Marvin's journey to understanding that the integration of models is most crucial, and how he entered the journey and how he's progressed through it.
Right. And the integration was not only integration of different theoretical approaches, but also the integration of research and practice. And that's how it started in graduate school for me. There was no integration of research and practice. And in many ways, my education at the University of Buffalo was a schizophrenic existence, not in a DSM sense, but here I was learning about research methodology, learning research and theory, perception on the one hand, and on the other hand, I was learning about therapy and assessment. And with therapy and assessment, there was no research, or very, very little research. And people were making statements like, here's the way you interpret the Rorschach. If somebody sees something off at a distance and it means they have a perspective on their life. So I see the sentence in a book, but there's nothing in parentheses. There's no citation. And it was very, very disturbing to see this gap between research and practice. So that's what got me started. I know we spoke about research, and we were going back and forth, you and I, Alan, about whether research is even possible. Anyway, a traumatic event that I had occurred when the clinical program invited Paul Meehl and visited us. And Paul Meehl was a practicing clinician, but also a researcher and a methodologist. And he gave a lecture, and then afterwards, a faculty person said, "Is there anyone who would like to go to dinner with Dr. Meehl?" And I figured, wow. So I raised my hand, I said, me, and there were a few other people, and we went to dinner. And over dinner, somebody asked him a question. "Dr. Meehl, to what extent does your therapy get informed by research?" And without any hesitation, he said, "Not at all." And even to this day, when I repeat the story, I feel this twinge within me of, well, if he doesn't, then there's no hope. So that was very, very disheartening for me. And then something happened in the late 50s. It was a book published by Joseph Wolpe. I don't know if you remember this. Was it 1958? Do you recall?
Yeah, well, actually, that was before my time, but I met Wolpe 10 years later.
10 years later, okay. Well, he published the book in 1958. And he said, we can look at therapy as a learning process, which I think people agreed upon. But he said, so we know something about learning. We know something about how people get conditioned classically, emotionally. We know something about operant conditioning and reinforcement. Let's apply this information to therapy. And we can then close the gap if we extrapolate from basic research into the clinic. That sound familiar?
Yeah, and Wolpe, we should, people may not know the names of Meehl and Wolpe. Meehl was the greatest, I think, researcher in psychology mid-century, from the 50s on. And Wolpe brought behavior therapy to the clinic. Skinner was really not a clinician.
Yeah.
Wolpe was the first great behavior therapist in America, a very influential figure in the field.
So this came out in 1958. I was a graduate student. I was in my class on learning theory. I brought the book to class and I showed it to the professor. And I said, look at this. Here's an attempt to bring learning theory into therapy. And his comment was, that's a lot of crap. It'll never go anywhere. Well, that was the beginning of behavior therapy. And then I lucked out in a major way. I lucked out because I heard that there was this university in Long Island that was going to be establishing a clinical psychology program. From the bottom up, there was no such program. And the idea was to have learning theory as its basis for development. Never heard of a place somewhere, very far from New York, Suffolk County. It was called Stony Brook. So long story short, I applied and was able to get a job at Stony Brook. And it was quite a heady time because we were one of the centers of behavior therapy. And the program was set up in such a way, and I won't go into the administrative details, which are interesting, but essentially pretty boring in some respects. We were able to get the clinical faculty to do therapy in our clinic and receive teaching credit for it. So instead of teaching a course, the faculty person had the option of doing therapy in the clinic. And the goal there was to get an ongoing clinic. And once we had the graduate program, because we didn't have it yet, the graduate students would do the therapy and we would do the supervision. And that was very, very exciting. So we did that. And we were applying classical and operant conditioning to various problems. And what we found out was it didn't always work. Now you might ask, why didn't it work? Or why do you think it didn't work? That was not a rhetorical question.
Why didn't it work, Marvin?
Well, Alan, I'm so glad you asked. So glad you asked. It didn't work because, and this was a clinic, I was seeing mostly graduate and undergraduate students as clients. It didn't work because these clients had this terrible habit of thinking. And there was no room for thinking in classical and operant conditioning, which that's all there was as far as research at the time. Cognitive science did not yet exist. So we were really at a loss. And the whole notion was, well, yes, it's a major paradigm shift to say we're going to base our therapy on research, extrapolation of research, rather than the psychodynamic and experiential therapies, which essentially base the therapy on therapy experience. So this was a major paradigm shift. We're going to know something about human functioning from laboratory studies, and we're going to apply it. I mean, it's what's called translational research now, where it's from bench to bedside, except it's much more biological. So it's a different bedside, it's a medical bedside. So anyway, getting back to the whole notion of cognition, is that we didn't quite know what to do because the research literature had nothing in cognition. And then what started to happen, though, in the late 60s, is Albert Bandura at Stanford started doing work on cognition. Albert Ellis, in his clinic in New York City, started doing work on rational therapy, which later became rational emotive therapy, which later became rational emotional behavior therapy. He kept including everything in it. And then, of course, Beck in Pennsylvania, working on cognitive therapy. But we were all separated, doing our own thing. And then we started to get in contact with each other, which was a little bit harder in those days, because we didn't have the internet. But we would visit each other. So Beck came to Stony Brook and spoke about behavior, wanted to know about behavior therapy. We wanted to know about what his notion was of cognition. We would then go to Ellis and deal with him. And of course, Bandura played a major role, as more Stanford PhDs, Jerry Davison, for example, came to Stony Brook on the faculty and brought all of that. And we would just hang out at conferences. We would go to dinner together. We would sit at the bar after the meetings and talk. And we decided we're going to try to introduce cognition into behavior therapy. That's a whole other history.
And I think they decided to introduce behavior therapy into the more cognitive approaches.
Exactly.
It was an integration of the two schools, twinning and coming closer and closer and finally joining.
Right. And it was fraught with a lot of conflict. So Michael Mahoney, who had an untimely death, was a major leader in the integration of the two. He had a background in strict Skinnerian conditioning and therapy. And as he became interested in the work that Beck was doing, he was cornered at a behavior therapy meeting by former operant colleagues. And they were trying to put pressure on him to stay away from this cognition. So, behind the scenes is where a lot of the field developed. So there was a lot of this stuff behind the scenes.
I can mention one thing that may be of interest here.
Yeah.
That Beck himself was a psychoanalyst by training. And he was hoping originally that his cognitive therapy would be seen as within the umbrella of psychodynamic treatments. He was rejected for inclusion in the American Psychoanalytic Association. And he pulled away from the Psychoanalytic Foundation. But interestingly, that reversed as cognitive therapy continued to grow. So the original treatments were symptom treatments, short-term symptom treatments. But many of the treatments didn't work. Why didn't they work? Because people had personality features that prevented them from participating fully in the symptom-oriented treatments.
Exactly.
And he began then thinking about those personality features, and gradually cognitive therapy began to tackle some of the same questions, some of the same problems that were the subject of psychodynamic treatments. And the treatments became longer. They focused on underlying, more unconscious processes, less symptom-oriented. They called it schema, a different name, but a really very similar concept. So we can see an integration here of three things, not just two, of the original behavioral approach that you were taught and that you began teaching, the cognitive approach that Stony Brook then integrated, and also really it's including the psychodynamic approach.
Exactly, yeah. So in a sense, and the integration of cognition into behavior therapy formed a pathway for psychodynamic stuff to come into behavior therapy. And Paul Wachtel wrote about this and trained at Stony Brook. And he wanted to add action to insight So he learned his action at Stony Brook to insight. And then the therapy became a combination of the two. Now, he didn't develop cognitive behavior therapy. As we know, each approach has a different name, but it focuses pretty much on the same type of phenomenon. So there are a couple of other instances that I experienced that really brought me to the final conclusion of we got to do something about this to integrate not only research and therapy, but also the different orientations. One of them was I was doing therapy to demonstrate behavior therapy behind a one-way screen with the graduate students watching from behind. So I took a woman who lacked assertiveness. I figured this would be a nice, clean case. And I would demonstrate how training in assertiveness could produce change. So here I am doing the therapy. And in one of the sessions, I noticed that she's being very unassertive with me. And I figured, okay, I really should comment on this. And then I thought, oh, no, that would confuse the students because this would not be behavior therapy. We're focusing on what went on between sessions. We don't deal with the interaction. So I let that go. And then in another session, she was talking about her emotions and how she would get angry sometimes and burst out in anger. And I figured, oh, I'm going to link that. I could link that to her lack of assertiveness. And I said, no. And I thought, no, I can't do that because that's going to confuse the students. So one day I shared this with the graduate students. And they said, please forget about demonstrating CBT. Demonstrate what you usually do. And that was liberating for me. I see that as my coming out from behind the mirror and doing what I would want to do. So that was one pivotal experience. The second pivotal experience.
Let me just say that. Again, this is, I think, the most important thing we could convey to the people that listening and watching.
What is that?
Follow the patient.
Yeah.
Don't follow the theory. If you follow the theory, you'll always be behind. You'll always be imposing your view of things on what needs to be done. And intuition and following the patient is the best guide to a successful therapy and really the best way of understanding therapy.
I like that. Follow the patient, not the theory. We should have that framed.
Yeah.
And
also follow the patient, not the supervisor. Because the supervisor.
Well, it depends on the supervisor.
Well, the supervisor will always be a week late.
Yeah.
So
well, that's true. Also.
Tells you can be useful, but it may not be timely. You really have to be listening carefully to the patient and trying to empathically figure out what will be most helpful for that person at that moment.
Yes. Great. That's a great lesson. Great lesson. So that was essentially what I did, even though I did it unconsciously, without the, pardon the expression, unconsciously, but I did it without the cognitive thought. The second pivotal.
Let me pick you up on that. Are you ashamed of the expression unconscious?
No, I'm not ashamed of it. It just makes me nervous.
Why?
As a behavior therapist, I say I have a conditioned emotional response to when I say unconscious, but I think it's getting.
How about as an integrationist?
Oh, that I could do. So here's the second pivotal experience, a very pragmatic experience. We got visited by the American Psychological Association to accredit our program. And they looked at my syllabus, which was all behavior therapy with some cognition in there and nothing else. And they said, we cannot accredit your program unless you expand and include other approaches. So the faculty, I remember in the meeting, said, Marv, you've got to do this. And I said, I don't want to. I've left that stuff behind. I've had enough of that. This is my new life. I said, well, if you're teaching the course, we're not going to get accredited. You have to do it. So reluctantly, I went back to my old notes and my old textbooks and put together information. And as I read this stuff, I looked at it and said, this is very familiar, except that the language is different. And that got me interested in the possibility that we're using different words, to refer to the same phenomenon. And this eventually got me into thinking maybe we should look at common principles, do away with the jargon because that is confusing us, forget about the techniques, at least for now, of how to implement the principle, because the techniques are going to vary from one orientation to the other. But if the principle is the same, if the patient has to be motivated to do therapy, regardless of the therapy, it's a principle of motivation. If there needs to be a good therapeutic connection between the therapist and the patient, regardless of the therapy orientation, this is a common principle. They need to become aware of what they are doing and why it's problematic in their life. They need to make use of their metacognitive ability to step back and recognize, oh, I'm doing this now, and look at the negative impact it's making. They need to then take risks and have corrective experiences by doing things differently. So this is something that I started thinking about. And I wrote an American Psychologist article in 1980 to deal with this. And I also edited an article that appeared in the journal Cognitive Therapy and Research, where I sent a questionnaire to leaders in the field: Jerome Frank, Julian Roda, Hans Strupp, Merton Gill, Arnold Lazarus, Jerry Davison, asking them these questions about motivation, about the relationship, about awareness. And they all said pretty much the same thing. This article has been buried and unavailable for decades because it's never been scanned. It appeared in 1980. And I've just last week got a copy of it, a PDF, and read it. And it's like, oh my God, this is amazing. This is totally amazing.
I read it too, and it really would be great to make it available to the people watching this if there's a way of doing it.
I could easily do that. Just send me an email, and I'll send you the PDF. My email address is online. If you look me up under Stony Brook, you'll see my email address, which is marvin.goldfried@stonybrook.edu. It's
a remarkable paper because it brings together the very top leaders in the field, each of whom were identified with very different theoretical approaches. But in discussing how they actually do therapy, the commonalities stand out boldly and virtually no differences.
Yeah. The thing that I reacted to as I read it just earlier in the week, it's like, this is from the mouths of the people who we were respecting. And they were different factions within the field. There were experiential people in there too, different factions in the field that were not talking to each other. And these leaders were agreeing. I mean, their questionnaires were filled out independently, but when you put it all together, it's like, oh my God, this is mind-boggling. So it's a good article. I should probably post it on Twitter also. Okay, so that's my confession. So let me turn tables. How about if our next podcast, Alan, you do some confessions?
Yeah, well, I will, but I'm much less interesting than you are.
No. Quite the contrary.
We'll see.
Okay, well, what I want to know, and I think other people would be very interested, is what goes on when DSM is formed? What goes on behind the scenes?
I'll do a little bit of that, but that's boring to me. I'll do two things. I'll discuss the DSM process and what it can do and what it can't do and how it may apply to psychotherapy. But I'll also discuss how I was shaped into being someone who saw integration rather than separation as the way of doing and teaching psychotherapy and some of the training programs we developed years to do this.
That sounds good. The first part, I really want to know what goes on behind the scenes in DSM.
I will do that. But before we leave you, I think one other interesting historical note about Stony Brook, you've already discussed how your personal experience and the Stony Brook experience helped to integrate the behavioral and the cognitive and then the psychodynamic approach into a seamless whole if you get rid of the jargon.
Yeah.
Really, you don't have to feel I'm this or I'm that. If you're a good therapist, you're going to be good at all of these things, and you're going to do what the patient needs at that moment.
Yeah.
One other thing about Stony Brook was that you trained Marshall Linehan, and that DBT, which on the surface may look different and not integratable, DBT is completely integratable with what you taught her at Stony Brook.
Oh, absolutely.
The basic techniques of DBT aren't that radically removed from the basic techniques of behavioral, cognitive, and dynamic approaches. So we can begin to see a grand integration, a grand unified theory that would lead to one unified psychotherapy with a variety of offshoots. Yeah. And that all of these are important for clinicians to master. And anyone who says, I'm a DBT therapist, or I'm a trauma-informed therapist, or I'm psychodynamic, each of these limitations or reductionisms make a therapist less competent to deal with the patients they see.
I think that's a very interesting point. And because, yes, DBT is CBT with some other stuff. A lot of the people who are DBT followers, and there's a lot of great stuff to follow there, think that it's totally separate from everything else. And that would be a nice podcast to show how it really is linked to other things and is more integrative in a way. But that's for the future.
Here's a small anecdote, and then we'll stop.
Okay.
I edited Marsh's two books, both the big book on theory and the smaller problem-oriented book. And we named the book Cognitive Behavior Therapy. I had to twist her arm to do that. It was Cognitive Behavior Therapy of Borderline Personality Disorder. We didn't call it Dialectic Behavior Therapy.
Really?
I did it for a good reason and a bad reason. The good reason was that it really isn't that different. And I didn't want it to be seen as a hothouse that was so different from the rest of the field. The bad reason was I thought it wouldn't sell. It was called Dialectic Behavior Therapy. The latter reason turned out to be stupid, both theoretically and in terms of practice. It sold fine. The therapy is sold fine. But I think it's important that people not pigeonhole themselves. No one should just be a psychoanalyst, just be a DBT therapist, just be a trauma-informed therapist. People need to expand and learn the techniques that work.
Okay, well, I'll throw out something else, and I think we should really stop. Major problem with that. Well, several major problems. One of it's financial. The other is the narcissistic needs of people wanting to start schools. But there's another problem, and that is, what will the identity be of the therapist? Because I think these schools serve a very important function in giving a person an identity. They know what journals to read. They know what conferences to attend. That's who they are. I am a DBT therapist. I am a cognitive therapist. I am a schema therapist. I am a CBT. I am this. I am that. We need to have some way of replacing the identity. And
and I think that's a crucial point. I think that identity is a very noxious thing that holds back the field, but you're pointing out that people
need it. They need it.
Unless we can substitute a broader identity as I'm a fully competent, fully trained, flexible psychotherapist, they're going to want to cling to something that seems more concrete.
Yeah, and specialization may occur, and that might be the solution. Because when you go to a physician, somebody's a physician. What's the next question? What kind of doctor is he? Pediatrician, oncologist, endocrinologist, primary care. You've got your identities. So the identity is in the kind of cases that you work with.
But I think specialization has been the ruination of medicine. And I think it's also been the ruination of psychotherapy. And the question is, can we replace this push for specialization? Because I really think it's noxious to good patient care. But that's a subject for another discussion.
Okay. I think it's time to stop.
Okay.
Have a good day. Enjoy yourself on the beach.
See you next week.
Take care. Love you. Bye.